Hello and welcome to my channel. In this lecture we will be talking about the female reproductive system. So let's begin. The female reproductive system, or the internal organs, are the ovaries, the uterine tubes, and the uterus, and vagina, the inner side of the vagina. This we will be talking about in this lecture, and we will start with the ovaries. Of course, there are two ovaries. They are derived from the genital ridges in the abdomen and descend to the pelvis. If they are destined to be testicles, they will continue their descent through the inguinal canal to get external and lie in the scrotum in males. But now it rests in the pelvis as the ovary. It's derived from the paramesonephric or Mullerian duct. It's almond shape, as you can see here, and grayish pink. Smooth surface if before ovulation. After ovulation, because of continuous rupture of mature Graafian follicles and near the surface, so it produces the corpora lutea. This results in the rough surface of the ovary after ovulation. And of course, because of pregnancy and increased size of the uterus, displacement of the uterus, the ovaries also change their position slightly after pregnancy. As you can see here, this is an ovary, and these are the two ovaries in relation to the uterus. The lie of the ovary, almost vertical in its ovarian fossa. The fossa is bounded anteriorly by the obliterated umbilical artery, posteriorly by the ureter, as you can see here, and the internal iliac artery posteriorly. And as you can see here, it gives the obliterated umbilical artery that will become anterior to the ovary and ascends on the anterior abdominal wall towards the umbilicus. This is the boundaries of the ovarian fossa. Laterally, it's the lateral pelvic wall, and medially, it's the uterus with its tubes. The ovary, to describe the ovary, we have two borders, the mesovarian border and the free border. Two surfaces, the medial surface, the one we are looking at here, and the lateral surface. Two ends, the tubal end and uterine end. This is the tubal end and this is the uterine end of the ovary. We will talk about each. The tubal end of the ovary, it's superior, of course, towards the tube, fimbria of the tube, so that's why it's called tubal end. It's near the external iliac vein, as you can see here. And it has the fimbria attached to it, fimbria of the uterine tubes. The suspensory ligament of the ovary coming from lateral to medial and carries the blood vessels that supply the ovary. The blood vessels and nerves that supplies the ovary. It crosses the iliac vessels and then behind the peritoneum over the psoas major, behind the cecum on the right side and descending colon on the left side. It's a fold of peritoneum that contains the ovarian vessels and nerves. Now, the uterine end is more tapering and slim than the tubal end. It's attached to the superolateral angle of the ovary, of the uterus, by the round ligament of the ovary. Now, the right ligament of the round ligament of the ovary and the round ligament of the uterus anterior, both are continuation or resemble the remnants of the gubernaculum. The gubernaculum was responsible to pulling the distant testis downward in the scrotum, but now in the case of female, it remained and atrophied into these structures, the round ligament of the ovary and the round ligament of the uterus. Remember this because this is a multiple choice question. The round ligaments of the ovary and the uterus represents the remnants of the gubernaculum. So these are the ends of the ovary. The surfaces of the ovary, we have the lateral surface. The lateral surface is the surface on the other side we're not looking at here. It faces the lateral pelvic wall, separating it from the obturator nerve and vessels on their way to the obturator canal at the upper border of the obturator internus muscle and the obturator membrane. We studied this in the pelvic wall. The medial surface is largely covered by the uterine tube, because the uterine tube ascends on the mesovarian border, crosses the tubal end, and descends on the medial surface of the ovary. This is the anatomical position of the uterine tubes in relation to the ovaries. As you can see here, it invaginates the posterior layer of the broad ligament, which is derived from peritoneum. It has a mesovarian border, the stem that connects it to the posterior layer of the broad ligament. See, this is the mesovarian border, and this is the mesovarium itself. It's like a mesentery that we studied with the intestine. Through the mesovarium, the blood vessels and nerves reaches the ovary and enters through the hilum of the ovary. The free border, as the one you can see here, is posterior and convex and faces the ureter and internal iliac artery, the posterior boundaries of the ovarian fossa. This is the free border, and this is the mesovarian border, and this is the mesovarium. Now the tube ascends on this border, on the mesovarium, crosses the tubal end or over the tubal end, and descends on the medial surface of the ovary. There are vestigial structures, remnants of, since this is a female, so there are remnants of the Wolffian duct or the mesonephric duct. As you can see here, this is the Wolffian duct, this is the Mullerian duct that became the uterine tubes and give rise to the uterus as well. See the remnants here in the Wolffian duct that was destined to be the epididymis and the efferent tubules from the testis, now became vestigial, and the remnants are called, see, as you can see here, the epiofferent and the paraofferent. The epiofferent and paraofferents are the vestigial remnants of the Wolffian duct on its attachment to the was destined to be a testicle. You can see them here. They lie in the broad ligament between the ovary and the uterine tubes, as you can see here. Okay. The blood supply of the ovary, of course, the gonadal or ovarian artery in this case. Remember, the ovarian artery was rising from the aorta, anterior surface of the aorta, just below the renal arteries. Remember that, the gonadal arteries. Now, arises from the aorta and pass infralateral on each side behind peritoneum on the psoas major muscles. Now, the relations of the right artery will be different than the left artery. The right artery behind the third part of the duodenum, right colic and ileocolic vessels, the root of mesentery of the intestine and the terminal ileum, and descends anterior to the inferior vena cava. And when it was on the psoas major muscle, the gonadal vessels were superficial to the ureter and the genitofemoral nerve. Remember, the ureter was sandwiched between the genitofemoral nerve deep to it and the gonadal vessels, or in this case the ovarian vessels, as you can see here, superficially. This is on the right side. On the left side, it descends behind the inferior mesenteric vein and left colic vessels and the lower part of the descending colon till it enters on both right and left sides, enters the suspensory ligament of the ovary to deliver the blood supply through the mesovarium, through the hilum of the ovary to the ovary, and supplies the tubes as well. On both sides, as I told you, it's related to the genitofemoral nerve and the ureter, and enter the suspensory ligament, become part of the broad ligament, see, and enter the mesovarium to supply the ovary. On both sides, the arteries give branches to the ureter as they descend. Remember, because the ureter was a long structure, so it takes its blood supply from different sources. It supplies the fallopian tubes, see, the branches to the fallopian tubes, and communicates at the end with the uterine artery, okay, uterine artery to supply to continue the supply of the uterus. Now, this is the round ligament of the uterus arising from the superolateral angle. See, there is a branch from the ovarian vessels to the round ligament of uterus, and this branch will go with the round ligament of uterus, so it will pass the inguinal canal and end by supplying the labia majora. Now, this is for the blood supply. Remember that also along this route, the round ligament of uterus, the lymphatics go to the superficial part of the pelvis and perineum. Lymphatics here drain with the round ligament to the superficial inguinal lymph nodes. It sounds odd, but remember that the isthmus of the tube and the superolateral angle of the uterus drain their lymphatics into the superficial inguinal lymph nodes. Okay? This is very important. The ovarian veins, just like the testicles, they start by a pampiniform plexus of veins that surrounds the ovary and drains the ovary. Then they coalesce to form around two veins that ascends in opposite direction with the artery, and it communicates with the uterine venous plexus. Now, the right ovarian veins drain into or open into the inferior vena cava. The left ovarian vein, on the other hand, because there is no inferior vena cava on the left side, it opens into the left renal vein. Remember this when we studied the renal vessels. The renal vein drained, the left renal vein drained the left gonadal vessels. In this case, the ovarian vein. And the veins hypertrophy during pregnancy, of course, to meet the demands of the growing fetus. Now, lymphatics along the vessels to the pre-aortic and para-aortic lymph nodes. Remember that. Okay, so now we are draining the ovary and draining the lateral side of the tube, because multiple drainage destinations for the uterus and uterine tubes and the ovary. Remember this, that lymphatics go along the vessels to the pre-aortic and para-aortic lymph nodes. The nerve supply of the ovarian by the ovarian plexus of nerves is derived, since the vessels coming from the aorta, so it will bring with them extension from the celiac plexus along the vessels to the ovary. Okay, celiac plexus to the ovary and uterine tube, and also enforced by extension from the renal and aortic plexuses and by the superior and inferior hypogastric plexuses. Superior and inferior hypogastric plexuses. As you can see here, the superior hypogastric, and this is the inferior hypogastric, forming on the lateral pelvic walls. Now, the sympathetic is sensory, afferent, and the parasympathetic mainly efferent to the vessels. And how did it reach here? From extension from the inferior hypogastric plexus And how did it get to the inferior hypogastric plexus? From the pelvic splanchnic nerves. Remember when we described the parasympathetic supply of the hindgut? We learned that the parasympathetic climbs on the inferior hypogastric plexus and the presacral nerves and the superior hypogastric plexus and then aortic plexus and then descend with the inferior mesenteric plexus. This is the same idea here. The parasympathetics climbed to the inferior hypogastric plexus and then supplied the ovaries and tubes. The uterine tubes, on the other hand, they are about 10 centimeters long, and they join the uterus at the superolateral angle, as you can see here. Each tube has an intramural part. Intramural means part of the muscle wall of the uterus. It has a course inside the muscle wall of the uterus. Then the isthmus, which is this part, isthmus, the narrow part, it's very narrow part. Then the ampulla of the tube, the one you can see here, this is the ampulla, the widest part of the tube and the site where fertilization occurs. Then the infundibulum, as it's a funnel-shaped end of the tube with finger-like projections called the fimbria. The fimbria to pick up the fimbria and infundibulum on the medial surface mainly of the ovary to pick up the ova, and that will travel along the uterine tube to the uterus. Okay? So these are the parts of the uterine tubes. As I told you, the fertilization takes place in the ampulla. Now, it takes around a week or so, or 10 days, for the ova, the fertilized ova in this case. Imagine the sperm has to climb all over the uterus and then enters the tube and fertilizes the ova in the ampulla. Now, the ampulla, on its way back to the uterus for implantation, the fertilized ova, if something impeded the migration of the ova through the tube to the uterine wall, implantation is destined to happen, either inside the tube or inside the uterus. In this case, if there is impedance of the migration of the ova to the uterus, so it will plant itself in the wall of uterine tube. Of course, the muscular wall of the uterine tube is much thinner than the rest of the uterus, and it lacks the endometrium, the mucosa, the essential for implantation. So the ova will implant itself in the tube. The fetus will grow. It can grow up to the size of 3 months pregnancy, and pregnancy may be diagnosed as normal pregnancy in this case, but suddenly, because the wall cannot bear anymore, cannot hypertrophy anymore with the increased demands of the fetus, the wall will tear or rupture, and this will cause severe internal hemorrhage. This is an emergency case in pregnancy and called ectopic pregnancy. If ectopic pregnancy complicates, when it complicates, it will result in the tear in the wall of the uterine tube, and this results in severe internal hemorrhage. Why? Because we have increased vascularity because of the growing fetus at this site. So remember the case of ectopic pregnancy and the causes that lead to ectopic pregnancy. Simple cause is inflammation of the tube before and formation of adhesions inside the uterine tube. Okay, remember the ampulla is the site for fertilization. The blood supply of the tube, as you can see here, the lateral third is from the ovarian vessels. The medial 2/3 is from the uterine artery, as you can see here, and the veins follow the artery, so the venous drainage of the medial 2/3 will go with the uterine vessels, and the lateral 1/3 with the ovarian vessels. see a big difference. This will drain into the inferior vena cava and left renal vein, and this will drain into the internal iliac vein. Totally different. The lymphatics along ovarian vessels, so it will reach the pre and para aortic lymph nodes because they arise from the aorta, and few to the external iliac lymph nodes. Around the isthmus, as I told you before, the lymphatic will go with the branch of the round ligament of the uterus and to the labia majora, and this will drain eventually into the superficial inguinal lymph nodes. Remember the lymph drainage of the uterine tube laterally to the pre-aortic and para-aortic lymph nodes, medially through the lymphatics along the course of the round ligament to the superficial inguinal lymph node. Of course, you expect that the lymph drainage of the rest of the uterus to the external and internal iliac lymph nodes. We will study this with the uterus. The nerve supply of the tube along ovarian and uterine arteries. The parasympathetic, because coming through the ovarian vessels, so it brings branches from the vagus to the lateral side. Remember that the vagus reaches the level of the superior mesenteric vessels approximately, but does not reach the level of the inferior mesenteric. So at the level of the superior mesenteric, there are the gonadal vessels. The vagus shares in the supply through the gonadal, through the ovarian artery, and the pelvic splanchnic nerves to the medial side. How it reached there? Again, the pelvic splanchnic climbed over the inferior hypogastric plexus and formed plexuses around the vessels supplying the pelvic viscera, and that's how it reached there, the pelvic splanchnic. So medially, the pelvic splanchnic, laterally, the vagus. And sympathetic, the origin is through from T10 through L2. The lower segments of the spinal cord, not the very low, but from T10 to L2, site of termination of the sympathetic outflow anymore. Okay, now there's a case called pyosalpinx in which there is increased chance of pelvic peritonitis in females. Why the infection is frequent in females? Of course, there are natural defenses that we will study in the vagina and the uterus, but eventually the microbial infection is increased in females because of the vaginal axis. So if infection occurs in the tubes, this and with pus formation, this is called a pyosalpinx. Another interesting info about the semen is that the prostaglandins in semen stimulate the muscle in the medial part of the tube, means it contracts the isthmus, and the medial side of the tube contracts the isthmus of the tube, so preventing the ova from entering the uterine cavity. So fertilization occurs in the ampulla, because the ampulla at the same time is inhibited by the prostaglandins present in semen. Okay, remember this, you will study this in physiology. So this concludes the talk about the ovaries and uterine tubes. Next time we'll be discussing the corpus uteri, the body of the uterus, and the cervix. I hope you got the maximum benefit from this lecture, and thank you very much for watching.